Topic for today is empathy and rapport. Our chairperson for today is Dr. Manoj Bhatavdekar, sir. Welcome, sir.
Good evening.
Sir is a consultant psychiatrist practicing in Andheri. Sir has been the past president of the Bombay Psychiatry Society, author of many books, and involved in many mental health programs in schools, colleges, and community in general. Welcome, sir.
Thank you so much.
Sir, if you would like to introduce the speakers.
Yes. Thank you, Prajakta. And thank you, IPS West Zone, for inviting me to chair this session on empathy and rapport building. It's Tenacious Tuesday Teachings, TTT. So let me complete the alliteration. It's Tenacious Tuesday Teachings by two talented teachers. So TTT by TTT. Well, as we know, empathy is at the heart of medical profession, especially when it comes to mental health. In our first MBBS itself, we had learned the Hippocratic Oath, which says primum non nocere. First of all, do no harm. See, we deal with people who are disturbed. They're seeking help from us with a lot of hope. They need to develop trust in the process of treatment, and for which we need to understand what they are going through. There's a saying in Sanskrit which says Paradukham Shitalam, which means the other person's sufferings are cool. They appear cool to us. But that person knows what that person is going through, right? So it is said that we need to put our feet into the other person's shoes in order to know how it feels. But we are stuck at a step which is before putting your shoes in somebody else's, your feet into somebody else's shoes. That is, you need to remove your own shoes. And I think that's the crux of the issue. We are stuck with our own biases. We are stuck with our own prejudices, belief systems. And more than that, we are burdened with our own knowledge, which we are not able to put aside when it comes to dealing with our patients. So empathy becomes a very important factor in the entire process of diagnosis, treatment, therapy, prescribing, whatever that you do, because it's the cornerstone of therapeutic relationship with our patients. Is empathy a trait? Can it be learned? Can it be taught? Can there be classes on empathy building and rapport building? I think these are some of the questions that all of us have been grappling with. And today we have two excellent speakers, Dr. Shilpa Adarkar, who has been a very good friend of mine for years together. She's a professor at KM Hospital, Mumbai. And Dr. Sri Lakshmi V, as she's an associate professor, AIMS, Nagpur. And looking forward to an excellent session. So over to Dr. Shilpa Adarkar.
Thank you, sir. Thank you for your kind words. Should I share my screen? Is it visible?
Yes.
Yes, ma'am.
I think for some reason it went to second slide, but that's okay. Okay. So we will start with a quote from Dr. Helen Fishburne. She is the CEO of Canadian Mental Health Association, who says that practicing empathy helps us regulate our own emotions before we connect with others, and it also makes us feel less isolated. So what is empathy? Empathy is derived from a German word, Einfühlung. Ein is one, Fühlung is feeling. So one feeling or feeling into. Basically, it means understanding others' emotions, sharing their feelings, and responding with compassion and care. So, as Dr. Bhatodekar already said, it's like seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another. So, certainly, all of us know it's not same as sympathy. Sympathy is you feel something for others or for others' suffering, whereas empathy means suffering with others. Now, that suffering doesn't actually means suffering, but it means understanding through experience what the other person is going through. So, renowned psychologists Daniel Goleman and Ekman, they have identified three components of empathy. One is cognitive, which is the ability to understand another's perspective. So it's like I put myself in your shoes. I understand your perspective. Emotional empathy is the ability to feel what another person feels. So it's like I feel with you. I understand your feelings. And compassionate empathy is the ability to sense what another person needs from you. So it's like I understand what you feel and want to help. As Sir already said, is it inherent? Are you born with empathy or is it learned? So if you struggle to notice other people's feelings or you can't relate to other people's feelings, it's okay. There is good news that empathy is a skill that can be learned and developed over time. All of us can be empathetic. Some of us are naturally more empathetic than others. Or some happen to grow up in environments where empathy was taught. However, all of us have the capacity to relate to other people and share their emotions. And we have to thank our mirror neurons for that. So just a word on mirror neurons. There were some animal experiments with monkeys that were performed and found out that there are brain cells that fire when one performs an action or views another performing that action. But they say that it represents more than that. It represents abstract action and goal and facilitate empathetic resonance with others or connect with others. They are located in prefrontal cortex in conjunction with frontoparietal action planning network. So they connect minds and they help share emotions. So the golden rule when we learn empathy is treat others as you would like to be treated yourself, which involves active listening with an increased focus on understanding and validating another person's emotional experience. So the key here is to be genuinely curious, ask open-ended questions, and to pay attention to how the other person is feeling. So we have to pay attention to their facial expression, their body language, their tone of voice, a change in the tone of voice or change in any of these, for which we have to be observant as well. And that is where active listening comes into picture. So when you're listening to somebody, try and paraphrase. Like, okay, so you are saying that when this happened, you felt sad. Or when this happened, or before this presentation, you were having palpitation. That is paraphrasing the same what the patient or someone has said in other words, but like a gist of what that person has said. Ask open-ended questions. It's better to ask, so how did you feel at that time, than asking, did you feel sad? Were you angry? Those are close-ended. So we prefer to ask open-ended questions when we are actively listening, and also specific probing questions, meaning you are listening, the person said something, you may ask more details about it. So you just said that I didn't like it. So what you didn't like about it? It may be about the person, it may be about a situation, etc. So specific probing questions will give you more information. Use short verbal affirmations so that the person feels that he or she is being listened to. Okay, yes, all these would be short affirmations. Share similar experiences. Need not be in your own life, but maybe some other patient, or you can put that in the form of some other patient or somebody who's already present there in your ward or OPD. You could also recall previously shared information in your act during your listening actively. For example, so earlier you had said that you maybe separated from your wife, or it could be that you moved away from your parents. So then what did you do after that? Or where did you go? Or what happened? So it means the patient realizes that you've been listening to everything and you remember the information that was shared earlier, and now you are asking something about it. You may nod or smile while listening. Please maintain eye contact. You looking at your papers or writing something during the interview, it causes distracting movements. It causes distraction, those movements. So please avoid them while listening and display empathy, which we will come to. So when you practice or display empathy, which is putting yourself and imagining the same situation in, or how the person is feeling or that person's perspective, you have to stay out of judgment and listen. So it cannot be that someone shared some experience and you feel, oh, how can he feel like this? Or what is there to get angry about? Or what is there to feel sad about this? Or this person looks like a PD, or this person is like this. So don't label, even in your mind, even if you don't say it, it will affect your rapport and therapy and treatment later. Recognize that emotion that is being expressed by the other person and communicate that you recognize that emotion. I understand how you feel. I understand that you felt sad at that time. I understand that you felt angry. These are some of the empathetic behaviors. Take the trouble, smile, nod, we already said, but take the trouble to remember their names. Maybe you heard the name just at the beginning of the interview, or maybe this is a consecutive session and you already know the name. That helps. Give them your full attention. So you keep everything away. Many of the times we see residents, when they take history, they are writing something. They are in the process of filling something up or completing something. I don't think that helps, or that is empathetic behavior. All that you are listening to can be later put into various formats and your proformas. Be curious about their lives and interests. So if they say something, if you ask them, I'm sure that will come in rapport building, but if you ask them something about their family, then the next question should occur to you. So, oh, this happened. So how did this happen? So what happened after that? So, oh, you left this job. So then what happened? Because it's not just asking a question and noting down an answer. What they tell you, that should lead to more questions and you becoming more curious. Offer constructive feedback to them. Approach the conversation with an open mind, without, as I think sir already said about having our own belief systems and our own thoughts and our own prejudices. Be willing to listen. So that is the first part, or initial part, that when you're building a rapport, when you're meeting a person for the first time, be open, be willing to listen. Do not pass judgments. The best empathetic statement would be not saying anything and just listening. If you have to say something in between, you could just say that that must have been hard for you. I understand. Oh, I'm sorry to hear that. Or I hear you. So the person feels understood. And then we can work through this together so that the person realizes that there is help or he or she is not alone. Now, coming to empathy in psychiatry, very well put by Carl Rogers. And every word here is very important. To perceive the internal frame of reference of another. What empathy is. To perceive the internal frame of reference of another with accuracy and with emotional components which pertain thereto, as if one were the other person, but without ever losing that as if condition. So we are trying to understand the other person's emotion. We are not getting carried away into it. So it is as if I was in that person's shoes and trying to understand that emotion. So there was a study which has been published in BJP 2017, where they interviewed some psychiatrists and some residents trying to find out how they engage with patients, and from that they have come out with these different types of empathy that are used, or that those are the themes that emerged through that study. One is relational empathy, which involves understanding the patient, responding empathetically, constructing the patient narrative. The next is transactional empathy, where one negotiates about the treatment goals, where is the treatment control, what kind of treatment, and understanding of reality. And then comes instrumental empathy, where there is understanding patient behavior and affect, managing one's reactions to the patient, and guiding the patient. So if you see, it goes more from more natural to more directed or more thought about or more conscious. In therapy, there is an empathy cycle that has been described by Barrett and Leonard, which says that the therapist listens openly to the patient, which is what we already saw what empathy is about, resonates with that experience and expresses the resonance back. That is when the patient feels understood and expresses more with higher level of comfort. So this is what this is how empathy works in therapy. And my last two slides. When your mind is cluttered and chaotic, it can be difficult to notice your own feelings and obviously the feelings of others. So what mindfulness is awareness that comes with paying attention on purpose in the present moment and non-judgmentally. The reason why I have written it in different colors is because all are equally important. So paying attention on purpose in the present moment and non-judgmental. And this helps to calm your own mind. You become more aware. You can even connect better with your own bodily sensations and obviously with your feelings, and then the feelings of others. So you need to be present in the moment. You need to listen closely to their experience, their point of view, and respond appropriately. So for that, you have to be mindful. You need to understand that person is struggling. So you need to tune into how they are doing in order to understand what they need and how you can help them. That is what empathy is all about. So just to end by a quote by Brené Brown. She's an American professor, has many podcasts. She's done a lot of studies in vulnerability and other emotions. So we have already learned what empathy is. It has no script or no right way or wrong way to do it. By just simply listening, holding space, withholding judgment, and connecting emotionally, we are communicating that incredibly healing message, which is what all of us are trying to do, is you are not alone. Thank you for your patience. And I think I'll give to Dr. Sri Lakshmi for continuing, unless Dr. Bhatodekar has anything.
A wonderful presentation, Shilpa. Very
Thank you,
lucid,
sir.
very clear, and highlighting the importance of empathy as a very important attribute in healthcare. Over to Dr. Sri Lakshmi.
Thank you, sir.
Thank you, sir. Thank you, ma'am. And thank you very much for the kind words at the introduction. I'll just share the screen. Screen is visible. I'm audible.
Go to slideshow, Sri Lakshmi.
I have.
Yeah.
Okay. So good evening, everyone. And this is actually a topic that goes more or less hand in hand. I think what Shilpa ma'am did talk about quite a bit, you'll be listening from my end as well. But I think, as we all know in residency, the more we reinforce, the more we remember. So right from the first edition of the series, we're going with that principle. So I'm looking at going to talk about the rapport building aspect. And this is how I'm going about it. What is rapport? What is the importance of rapport? Factors affecting rapport, how we can go about attempting to build rapport. And of course, despite all our best efforts, there are certain difficult patients that we all may have to deal with. So and I'm thinking that part, I have way more senior people here in the as experts, so they can always pitch in. So just a word on certain difficult patients that we all have to deal with. So going to the basics of rapport, how do we define it? Well, in simple terms, to understand it, it's nothing but we say, click ho gaya. Yeah, the chemistry that kind of comes between two people. And if you're going to look at it from a clinical setting, well, it's a harmonious responsiveness of the physician to the patient and vice versa. So responsiveness and harmonious, I think, being the key words here. And well, when there is a good rapport, you feel positive towards each other, you're focused on and invested in each other, and there is an overall sense of harmony. So you know that you are having a good rapport when there's an increased flow of conversation. Things are just moving very smoothly, and even sensitive information comes out very easily. There's a relaxed body language of both the persons, and eye contact is usually better. Or if it's not initially, once rapport gets better, it gets increased and maintained. And even listening and responding gets better. So then you know you're kind of on the right track. And well, when there's no warmth, there's no attention, you feel incompatible, like you're not on the same page, you have that feeling of coldness, like something is not okay, you don't feel like the other person is seeing you or understanding you, or is really bothered about what it is that you're trying to say. And well, then when there's poor rapport, you can frequently have disagreement as well. So no rapport, when there is sudden withdrawal of conversation, there'll be long, awkward pauses or periods of silence where nobody knows what to say or how to go ahead in the conversation. Lack of eye contact, brief responses. You ask a question, you have like a 2-word, 3-word, or 1-word answer, and then again there's silence. And of course, defensive body language, sitting like this or just looking away, trying to move away. All of these things are things which tell you that, somewhere things are not going okay. There's no rapport happening here. So why is rapport so important? It's actually one of the very important things when it comes to positive patient outcomes. So if you have a good rapport with your patient, you have better trust, you have higher satisfaction from the patient side. So many patients come and say, bus aapse 5 minute mil liya, Dr. Saab, we feel so good. So that happens only when there's a good rapport. So there's much better satisfaction. If there is satisfaction and trust, you have better treatment compliance. So there is treatment adherence. They come up to you with issues or problems. They are more willing to listen to what you have to tell them about medications, possible side effects. So you have better treatment compliance as well. And even from a diagnostic point of view, we are at a better standpoint. Because if your patient has a good rapport with you, they trust you. So a lot of information that we're looking for when we're taking history, maybe sensitive information, they may be worried about confidentiality. So many a times such things are not shared because of these fears. So when you have a good rapport, the patient is in a much more comfortable setup to actually tell you these things. So many times it happens. The first setup, you've sat and talked to the patient and then you're breaking your head. Kya diagnosis? I'm just not able to understand anything. And then you spend some time with the patient, or after 2 or 3 sittings, suddenly silently the patient will come up and tell you some sexual complaints, or come up and tell you some history of abuse that has happened in the past, and then suddenly everything, kind of the jigsaw puzzle, comes together. So when you have a good rapport, it also definitely affects your diagnosis, helps you make a better or an adequate diagnosis. So all of these put together definitely improves patient outcomes. And in the long run, definitely, if you have a good rapport, there is reduced risk of litigation, something that we're all somewhere at the back of the mind worried about nowadays, about malpractice claims and having violence against doctors. So if you have a good rapport with the patient and the patient caregivers, there is definitely a reduced risk of litigation as well. So something very important for day-to-day practice. What are different factors that can affect rapport? If we can maybe have, since we've been listening for a while, can we maybe have some answers on chat? Prajakta, if you can help me with that, because I can't see my screen.
Yes.
Can you just, whatever comes to mind, what all do you think can affect your rapport with the patient? Any answers coming
Guys
in?
can type it in the chat if you don't have any answers yet.
Please do.
Anything, whatever.
Otherwise, then this just becomes a boring lecture. There needs to be some interaction. You meet patients, you talk to patients every day. So what do you think affects your rapport with the patient? Somebody is...
Someone's saying language barrier.
Okay. Something that I think many residents face when we go all across the country in residency.
We also have eye-to-eye contact, body language,
Okay.
and chaos in the casualty.
Okay, so the setting where we are in, rather the OPD or the casualty, especially in emergency settings.
Gender of the doctor.
Okay. You guys are making my job easier. I need some more answers. Any more? I can see one more coming.
Behaviorally unstable patient.
Okay. So keep thinking, and as we're going ahead, we can, discuss about many of these points will come up. So this is just to kind of make things more comprehensive. So you can have factors which are dependent on the patient. You can have factors which are dependent on the provider or the interviewer, being us primarily. There are factors where there is a patient-provider mismatch. And then, of course, there are system or environment-related factors. So what are these? Let's just explore them a little bit one by one. Some of the things you did touch upon when you mentioned age of the patient can be a factor. So especially when you're seeing patients from either extreme of age, with children and with elderly, in both cases, there's quite a bit, especially with children, teenagers, adolescents, where they are brought by the family to the OPD. They're not very keen on coming. Young children, you don't know how to have a conversation with them. You don't know what to say to them. Either we end up talking in a very baby language, which to some of them may even become offensive, or we just don't know where to gel with them. Elderly also, on the other hand, there is also a factor of them looking at us, especially when we are residents. in terms of the young age as हाँ ये तो बच्चे हैं, they kind of talk to us like they would talk to their children maybe. So sometimes the age in itself can become a factor which can affect the rapport. Sensory issues can be another problem. Again, something commonly we see with elderly, not only elderly, but otherwise. Like I remember with many elderly patients, you have problems with hearing. So you're trying to ask them questions in MSc, you're trying to assess for cognition, and if they just can't hear, it's very difficult for you to take any kind of history or do any kind of examination. So sensory issues, especially affecting hearing or vision, all of these can act as barriers. First contact with the patient. So it's the first time that the patient is coming to you or meeting you. That in itself can affect the rapport, how comfortable they are, how easily they are able to talk to you. That can be a factor. A lot of personal biases, of course, patients themselves coming in. So they've had some past encounter with psychiatrists, or they've had some, past experiences, stigma related to illness, what people may think. You have with so many, you'll see even with children, like the child is saying something to us when we are interviewing, and the parents immediately, अरे ऐसे बात नहीं करना है. Patients with psychosis, अरे ऐसा कोई गाली दे रहे, ऐसा नहीं बात करने का, and then they kind of try to get the person away. So personal biases about how one should behave in front of a doctor, how one should behave in a hospital environment, related to illness, related to other contact they may have had. These are also things which are bound to affect rapport. Transference is a concept which Freud gave us, where it's kind of an identification based on past experience. So that also can have, like if you're identified in terms of a child or in terms of a partner, so the kind of behavior that they have with you can definitely affect the rapport. This primary psychopathology of the patient itself. So you have patients with paranoia who may be very hypervigilant, not really willing to talk or share. You may have patients in mania who are over talkative, hyperactive, because of which it's very difficult to build a rapport, or over familiar, where the other extreme comes in. Patients with catatonia who are mute, who are not speaking. So these in itself also can affect the rapport. So the primary psychopathology or diagnosis of the patient can also be a factor. Difficult patients. So some patients require frequent reassurance. They have a lot of queries. I'm sure all of you must have seen some of these patients who come with one that you start asking them kya takleef hai, and they'll like 1 minute and they'll pull out this notebook or sheet of paper where they have written all each. So, and they want to make sure that as you are talking, each and every point that they have written gets covered. Okay, you try to bring the conversation. No, ye reh gaya, and they'll keep turning the page till they are done with an entire long list of symptoms. So such patients also can at times, patients who are hostile, who come with some sense, nowadays with health literacy and the ideas that people have with Google doctors, the moment you utter the name, oh, that's an antipsychotic, they've already read through half of the things, they've come. So that also affects in general the kind of attitude or thought process with many. I'm not saying all patients, but there are certain patients who come with that mindset that ये लोग तो पैसे लेने के लिए बैठे हुए हैं, ये लोग तो ऐसे ही behave करते हैं. They think they know a lot because I have researched, I have ADHD. So these kind of things also kind of affect the rapport that you build with the patient. And of course, relatives or caregivers can be a major factor. Their biases, their way of thinking about the illness, what they think is important and not important, all of this also affects our rapport building and the ability to take histories. When it comes to providers or us, of course, when we are in early training as residents, usually there is a lack of confidence most of the time, especially in first year and up to a significant part of second year. We are not sure what questions to ask. So you have patients who come, patients tell us a lot of things. So how to take this conversation ahead? Madam was talking about an empathy, that when you ask a question, you need to connect to the next question. We are so preoccupied with either trying to come to a diagnosis. So we have like a script कि ये सवाल पूछना है, MSc में we have to go from mood, affect, this, but that's not really how it works when you're taking the interview. So patient tends to deviate, things move another way. So that anxiety comes up. if you're in, like, when we used to sit in OPD in Nair, we had very often the faculty who's sitting there right in front of us. So being observed by a senior also very often is something that can cause anxiety and can affect your ability. Exams also, that very often happens. We elicited a lot of things that you're coming and sitting here, and then in front of the examiners, we have to elicit something. Your own anxiety can come in the way of building rapport with the patient. So these things, and then to the patient also, you appear कि अरे ये तो junior doctor है. So that attitude with which they talk to us also can affect our own personal biases, of course, of how I actually took a kind of a poll with some of my residents, asking them what issues they face. So many of them said, like, with patients of substance abuse, there's a lot of tendency to have a kind of bias against them. Many, before coming to psychiatry or as a psychiatry resident, very often think of ki ye aadat hai, people do it on purpose, which is what most lay public also think. So such kind of biases affect the way in which you deal or handle the patient as well, which is where, again, like transference for the patient, where there is counter transference here when it comes to us. So all of this can affect our ability to build a rapport with the patient. Your own communication skills. All of us are not born orators or speakers or not comfortable communicating in public. So each person in itself may have certain inhibitions, may have certain difficulties in communication. So these things also can affect how we talk to the patient. Madam already talked about multitasking. As a resident, I think we're all doing 100 things at the same time. You're seeing a patient in OPD, उधर ward से nurse का phone आ रहा है कि ये patient का कुछ तो है, वहाँ MRI गया patient, somebody has become aggressive, there is a call coming in. So you're doing all these things at the same time and trying to talk to a patient who's going through a lot of issues. So this in itself can be a major factor when you're trying to build rapport. Physician burnout is a definitive factor which impacts, because beyond a certain point, we learned about empathy. We saw what are all the ways in which we can work on empathy. When you reach a point of burnout, it's kind of like, I don't care, or I don't have the energy in me to care anymore. So that flatness that comes with it, it kind of becomes very difficult to talk to a patient or form any kind of, you start working on a very spinal level. हाँ ओपीडी में बैठना है, सीटी ऑल करना है, कुछ तकलीफ है क्या, कुछ दवाई है क्या, कुछ है नहीं है, right, and sit. So there's not even an attempt being made anymore to form a rapport. So that is something that Madam very rightly pointed out about mindfulness towards the end of her presentation. So taking care of ourselves and ensuring that physician burnout is minimized. In our setup, you can't say it is zero. There is a lot of work as a resident, no doubt about it. But at least when we take care of ourselves, we ensure that we minimize this so that it doesn't come in the way of our working. So these are all certain factors related to the provider or us in itself. Patient-provider mismatch. Somebody mentioned in the chat about language barriers. This is something that we commonly have. This is something that I have personally done myself, and I think that's very helpful if you can pick up the language. You're there for 3 years in a place where you're going to. Indian languages are not that hard, at least enough to a point that you can have a basic conversation with the patient, ask basic complaints. The happiness that you see, the comfort that they have in building a rapport with you when they know that you can understand what it is that they're saying in their mother tongue, there's nothing that can beat it. So language barriers definitely are there, but they're not something that are impossible to overcome. Of course, if it's a completely new language, do take the help of an interpreter. It can be the patient relative or the somebody there who can help you out in the OPD or the IPD at that point in time, because without that there can be a lot of difficulty in forming rapport as well as a lot of miscommunication when it comes to history. So language barriers can be a factor. Cultural barriers are again, so this is again something that the residents spoke about when I was taking the poll, that my hospital where we are right now is more of a rural background area. We have patients more coming from farming and rural background. So for people who come from the city, they're like, we don't even know what to have a conversation with them about in general when they talk about work, because they are talking about their worries about sowing of seeds and abhi ye season hai, and like other than whatever we may have read at some point in time in geography textbook, we don't really know anything about that on a practical level. So sometimes because of the socio-cultural barriers as well, certain things related to certain religions may be there. I think one of my SRs was talking about how in certain areas ghungat is something which is mandatory for women, or if you have Muslim religion women, you have parda that they have to wear. So all of these things also again become a problem when you're trying to build rapport with the patient, because for us the body language, all of this also becomes a very important part. So these could be certain cultural barriers that can come in, but also something that we have to be very sensitive to. Gender related is again that came out in the discussion. So we've so often seen such issues, no, that there are sexual complaints with the patient and they're not comfortable talking about it to the patient, to the doctor of the opposite gender. So they wait for a follow-up where they have a doctor of the same gender, or they ask sometimes, like patients who are coming to the OPD with sexual complaints in the first place generally ask right away that हमको मेल डॉक्टर से मिलना है या हमको लेडी डॉक्टर से ही मिलना है. So that also can be a factor which affects. If you're trying, there's no one else available, you're sitting and trying to ask questions, that can definitely affect the rapport and your history taking. Confidentiality is a factor very often which can affect rapport. So when they're taking history, they are not sure where you're recording it on paper or you're putting it on the computer. So there's a lot of questions in their mind when it comes to confidentiality. Who is going to be seeing these papers? What is really going to happen with this? So when there are especially sensitive issues, we're talking about sexual issues, we're talking about maybe history of abuse, we're talking about even in when you see with teenagers or children, so problem between husband and wife, these are all things, or with the daughter-in-law having problems with her in-laws at home. So there are a lot of things that come out when you're taking history. So if the person doesn't trust you or the environment that they're in, that feeling of lack of confidentiality is again something that can affect rapport. So I'm not saying anything, not because I don't really want to, but because I'm scared of what might happen with whatever is it that I'm saying. So this is something that probably needs to be addressed right at the start when you're talking to the patient. And of course, the other end of it is also there. It's not like everything that you say is 100% confidential. So I think a good in between usually is to tell, especially with teenagers and all, we see that there's substance use, there is cutting behavior or NSSI which is happening, and then don't tell my family about it. I don't want anybody to know. So these things, it becomes a very balance that you have to maintain between ensuring that the patient is safe and at the same time making sure that you're making them feel safe, that there is confidentiality. So this is a factor that can affect rapport. Locus of control come here in the context of who's in charge, in terms of who's in charge of the conversation, who is in charge of the treatment. I'm sure we've all seen patients who have come and said, ये इन्वेस्टिगेशन हमको कराना है, आप बस लिख के दो, या फिर ये दवाई काम नहीं कर रहा है, इसका पहला काम करा था, वो लिख के दो. Don't go anything beyond that. वो सीनियर डॉक्टर ने देखा है, आपसे बात नहीं करनी है अभी. So there, where you're trying, even an attempt to make a rapport is stopped right at the word go. So this kind of thing also, it can go the other way around also, that I'm telling you this, you have to take this medication and that's about it. So where there is a shared, a partnership, where there is collaboration in terms of the treatment and understanding things, is where you will have a good rapport. So these are some factors related to both the patient as well as the interviewer, which can affect one's rapport. And then, of course, things related to the environment, some of which many a times we can't have a control over. Time constraints, we all know how we struggle most often in OPDs. We have large number of patients waiting. We have a major time constraint to finish up. So there is very less time to actually sit and build a rapport with the patient and take a detailed history. Usually the consultant or the senior resident is breathing down your neck. कि अरे और उधर 10 पेशेंट खड़े हैं, खत्म करो. So time constraint definitely comes in the way. Space and infrastructure, we are all usually in tiny rooms where very often you can listen to what the other interviewer is talking about or the other patient is talking about. So again, for confidential matters, sensitive issues, it's very difficult to really have that good rapport or that conversation. And I remember when now the HMIS has come up in most places. So I remember when Dr. Supe had come to Nair to kind of say, so the way the HMIS system was being put was that the doctor is sitting here and the computer is put in front of the face. So I remember him yelling at the HMIS people कि अरे बाबा ये साइकेट्री के लोग हैं, इनको पेशेंट को देखना पड़ता है, तो प्लीज वो स्क्रीन को हटा दो या साइड तो भी कर दो या लैपटॉप दे दो. So that infrastructural limitations that come up sometimes is also a difficulty that is there as part of the environment. High patient provider ratio. This is something very often that happens during rounds. You have one patient who's sitting on that bed, and then you have some 7-8 doctors or more than that who are surrounding the bed. If you have interns joining in for rounds as a large group, patient is so afraid. There is no conversation that can happen in that kind of a ratio. So where there is higher provider ratio than the patient, that definitely affects the rapport. Emergency care setting, somebody mentioned, you have so much of chaos that's going on. There's so much noise. There is some patient critical in one corner, the CMO is screaming, there are some other relatives there, it's a mess. And that is usually the kind of situations where you have patients with suicidal ideas, you have patients with conversion disorder who have come. So that kind of setting also very often becomes very difficult to establish a rapport. Documentation burden, I'm sure all residents can relate to this, to the number of notes you have to write, to put entering things on the system. So I think Madam also was talking about that when you're taking history, when you're talking, most of the time the hurry is जैसे जैसे बात किया याद रहना चाहिए, वैसे वैसे हाँ क्या चल रहा है, हाँ. So you're barely even looking at the patient. I have seen some residents even doing this. हाँ कहाँ रहते हो आप, क्या एड्रेस है आपका. So they are not even looking at the patient. Where is the question of rapport even going to come? It feels more like a police interrogation rather than a interview or a history taking. So that burden is there for documentation, but that invariably affects how you're building rapport with the patient. And the cost overall of treatment is also something that affects. So patients going through a lot of issues, they drop out of treatment, they find it difficult in terms of coming. So because of that, when they come, they don't share a lot of things. That affects their rapport. They try to minimize things as much as they can so that they can just finish up quickly. So these are some systemic things. Many of these things are not in our control. But despite all of this, how can we really go about, what can we do to kind of work on rapport is something that, because there are always going to be limitations, there are always going to be constraints. But what we need to learn to do is how we can improve ourselves despite all of that. So that's what we are going to look at. Many of these things Madam has already touched upon, so I'm not going to dwell too much on them. But yes, this is definitely a reinforcer for you all. So how to go about building rapport? First and foremost, I think, is be aware, be present, be attentive. If you are there in the moment, definitely it's much easier for you to have a conversation with the person. It's very important and easier for you to observe the small, subtle changes that happen in body language, the tone of voice of the person, despite all the chaos that may be going on around you. Your focus and your attention, if it is on the person that you're talking about. So time constraint, yes, but that 5 minutes when you're talking, so many times residents miss out very simple things like there are some movement disorders that is there. So some grimacing, pouting of the mouth, some small fidgetiness that is there. These are very subtle signs. So if you're attentive, if you're observant, and you're in the present moment, you're much likely to have a good rapport with the patient because they understand that you're there for them, even if it is, they all know. None of our patients are in any kind of illusion that you have hours together to sit with the doctor. They all understand the OPD, the crunch, and all of that. Once you go into private practice, maybe eventually you take your time. But until then, everybody understands. But that 5 minutes that you're giving them, give it to them with all your attention. That's all that it needs for you to build a rapport with them. And of course, empathy, empathy, empathy. That cannot be stressed on more. It is very, very important. If you have that, definitely you have a good rapport, because then you're always thinking from the point of view of the patient, from the point of view of what best you can do for them. So the concerns of the patient are definitely addressed. And when that happens, you have a good rapport with the patient. So you ensure their comfort, Some of the things that very often happens with residents also when they're having conversations, बहुत बार होता है शुरुआत कैसे करना है, like how do you start a conversation, how do you go about, because psychopathology in itself sometimes may be something that the patient is not with. Some patients come, they sit, they tell you क्यों आए hospital में, and they'll tell you the whole long list of things. But with certain patients, many of them are not comfortable at the get-go. So talking or asking about general things. We do have demographic details as start part in history. So talking about family, asking about, when you're talking, also be sensitive of how you're asking. I've seen people ask about shadi hui hai kya? Nahi hui. That's definitely not a way to go about when you're trying to build rapport. So try to be sensitive of how you're wording the questions, but general words about family, trying to ask them about what they do, their occupation. These are starting points that can help you get into the conversation, make the patient also feel comfortable so that you can move ahead. Build confidentiality and trust. I did touch upon this when we were talking about the factors, but I think we can't keep them in an illusion as well that जो कुछ भी आप बोलोगे ये कोई भी बात बाहर नहीं जाएगी या nothing of this will be told. One thing, always make sure that if for any reason you're afraid about their safety, that is a point where you cannot just keep the shield of confidentiality anymore. And this is something that you need to calmly, categorically tell the patient as well, that now my concern is more for your life and your safety. So in this situation, I need to ensure that you're kept safe, for which I'll have to include a family member, whoever it is they're comfortable with, we can. But that is a point where I think it's a no in terms of keeping things hush hush because they're trying to cut themselves or they're trying to harm themselves. But otherwise, with other, sometimes you have to actually say this to patients, ki don't worry, we are here for you, we want to let you know what things are. So आराम से आप बात कर सकते हैं. What you say here will be in this room with us. So this is something that is very important when you're building a rapport, and of course, interest in patient concerns. You may be bothered about the movement that the patient is having. They may be bothered about the cost of the treatment. So where their concerns lie is also very important when you're trying to build and maintain a rapport with them. Be respectful of their wishes and needs. Be very mindful of language as well as cultural differences. So if someone is unable to understand the language, use an interpreter, not an issue. If you learn the language, there's nothing like it, but use an interpreter. Don't trouble either side. You also don't get troubled by it. You don't trouble the patient also in taking such a long time to just share some 2 lines of their history. And of course, make sure of cultural differences. So if it's a female patient who's in a ghungat or a burqa, if she's uncomfortable in front of a crowd, see if you can, do the examination or talk to her separately. If you're a male resident, keep a female, staff or someone with you. And then you do the examination where they have to take off the burqa so that you can observe. So in these kind of things, if you're mindful, it's much easier for us to have a rapport with the patient. Be mindful of sensory issues is something that my teacher taught me, Alka ma'am in Nair. So with patients who have conductive hearing loss, if you actually she used to tell us to put a stethoscope in their ear and use the end of the stethoscope to talk to them. And actually, if they have a conductive hearing loss, the patients can hear. And you should see the smile on their face when after 10 minutes of asking questions, they couldn't hear a word. But when you do that and they can hear so clearly what it is that you're saying. So if they have a hearing aid, make sure they have the hearing aid on. If they have chashma, make sure they're wearing the specs. All of these small things can ensure that they know what it is that you're saying, they understand, and you have a good rapport. Non-verbal communication on your side is also something that's very important. Ma'am was talking about nodding, how you're sitting also. So if you're having a very cross arms, you're sitting in a very, non-interactive manner, non-engaging manner, the person itself, when you look, it's obvious that you're not interested. So if you're not interested, you're not engaged in this conversation, which means there's no point in going anywhere further. So all of this kind of non-verbal, you're nodding, you're giving eye contact to the patient, you're paying attention to them. All these factors definitely go a long way in forming a good rapport. Open-ended questions, we've already touched upon that. And these are some things during interview that help. So I think Madam has already talked about many of these things. So reinforcement. So usually, So when you're asking questions or they're giving history, you're nodding, you're making these sounds, you're asking them, acha, or fir kya hua? So they understand that you're interested and you're, continuing to show interest, which means they can keep talking. Reflection and summarizing what they're saying. So ma'am talked about paraphrasing. So paraphrasing would be where you are saying what they're trying to say with slightly different words. Summarizing is generally at the end of the conversation. It's a good idea. Like if they have been telling you about chief complaints, it's a good idea for you to summarize their complaints or summarize what it is that they have said so far. One, it helps you also put your thoughts together, because sometimes the conversation has gone on for some time. And two, the patient understands you've been listening. They know what it is that you're saying. Three, it also helps you clarify. At the end of summary, it's a good practice to usually ask, or kuch, like, is there something that I've left out? Yeah, is there something that needs more clarification? So it becomes easier and goes a long way in your rapport. Reassure the patient, encourage them. So with many patients, it's also helpful to tell them, it's so good that you've now come to seek help, that it's a good thing that you have come this far. I see you've gone through a lot of issues, so finally you're now here to seek help, which is a good thing. So let me see what I can do to help you out. So that encouragement is something that some of them need. Acknowledge emotions. This is something I think that's very important when you're conducting an interview. If your patient cries, if your patient is getting emotional, tearful, give them a pause, give them that few moments. Tell them, like, if you're saying, I can understand you're going through a very difficult time. Usually, if you have, it's a good practice to have tissues next to you on the table. So you can just offer them a tissue, offer them water. Don't go on with your, agla question. Okay, so that is something that's definitely important. So emotions can be, very often you have tears, it can also be anger at times, it can also be irritability. So it's a good practice to acknowledge the emotions. I can see कि अभी थोड़ा सा you're getting irritated. So can we talk a bit about that now? कि क्या हुआ? I mean, what happened that got you to feel like that? So then the person also understands कि something I'm going through, whoever this is talking to me has understood that something has changed. So maybe I should continue with this conversation. So less chances of them becoming very hostile. How you transition the conversation. Madam was talking about moving from one question to the other. So that is also very important. Very often patients are giving you a lot of clues when they are talking. So yes, आपको history लेना है, yes, आपको HOPI लिखना है, लेकिन when you're talking, the patient has not read the textbook and come. So the patient is not going to tell you whatever they're saying in the order of that. It's up to you to gather all the information, consolidate it, and put it in your format. But when you're talking to the patient, those kind of transition. So I have sometimes heard patient has started talking about बच्चों का ऐसा तकलीफ हो रहा है, ऐसा कुछ है, and then suddenly he'll go, आपके काम पे क्या चल रहा था? So that's like a complete 180-degree turn in transition. So that is something that is better avoided. You stick to or try to continue on with the conversation. You get a lot more information when you go that way, and they are also more comfortable talking about it. Silence is something that is very important in our conversation, sometimes even much more than words. So when there is silence, try to make use of it, try to understand why there is silence in that moment. Try to interpret that silence. So silence could be because they're awkward, they don't know how to continue the conversation. Silence could be because they're feeling very tearful at the moment, they don't want to break down or cry. So depending on what's going on, changing the tone of your conversation, your body language will be very helpful for the rapport and to continue the conversation ahead. Humor is also something that's helpful at times when you're having the conversation, to kind of make a break in the topic or to kind of change the mood of the conversation. So it's not that, please don't make it like you're laughing at the patient, but using it sensibly to kind of lighten the mood in the situation is definitely something that can be done. So these are all points which definitely go a long way when we're talking about building rapport, having a conversation. But at the same time, it's also important, I think, more than knowing what to do, it's important to know what not to do. So closed-ended questions, starting off straight away with them is a definite no-no when you're trying to build rapport. Asking very complicated questions. You word 2-3 questions together into one question. So patient at the end of it is wondering, "Ko pucha kya tha? Main jawab kya दूं?" So those kind of compound questions are difficult. Why questions? शादी नहीं हुई, क्यों? What are you expecting them to answer? बच्चे नहीं है, क्यों? Is obviously not something that will help with the rapport. So these kind of why questions worded in that manner can be more hurtful and definitely will not help in your rapport. Judgmental questions or statements. Ma'am has already talked about this. So our own biases, or you may think drinking or substance use is a problem. You have a patient who has that. That is his illness. So when you're taking your history or when you're talking to the patient, that is where the conversation is going to go. Your personal bias coming in the way is wrong. Minimizing patient's concerns. They are talking about side. ये कुछ नहीं है, ऐसे कुछ होता ही नहीं है, आप बिना काम का बहुत चिंता कर रहे हो. So this is again something which will come in the way of rapport. Giving premature advice or interpretation before you've taken your history. Patients very often ask before all the details have come, ये ठीक तो हो जाएगा ना डॉक्टर साहब, ये कोई बड़ी बीमारी तो नहीं है ना, ऐसे कोई प्रॉब्लम तो नहीं है ना. तो before you've gotten all the details, if you're giving false reassurances, you're interpreting or giving advice, that can also create problems. Abrupt transitions I've already touched upon. Using very technical language when you're talking to the patients or the patient relatives, talking in a very, using all these big words, technical words. I've heard some people even say neurotransmitter ka problem hai. I'm pretty sure they're not able to understand any of that. So what language you use when you're talking to your patient will definitely matter when you're building a rapport. And then of course, we talked about multitasking and the 100 interruptions. If at all it is, like sometimes it becomes urgent, there's a violent patient in the ward, there are problems, you have to pick up the phone. Tell your patient, no, just 2 minutes, thoda sa kuch urgent phone call hai, just 2 minutes, I'll get back to you. They'll understand rather than they're talking and as they're talking, you just pick up the phone, go hello. So obviously that's not going to help. So these are some things that we need to avoid as far as when we are talking about when we are building rapport. Non-verbal communication we did touch upon. So coming towards the end of the presentation, these are, despite all our best efforts, there'll be certain patients with whom we all have difficulties. Things definitely improve with experience, but there are certain patients where we ourselves get into an issue how to go ahead with this. So you have anxious patients who keep on repeating the same thing again and again, or who are very restless, they're not very comfortable with the conversation. So trying to build a rapport with them, trying to take history from them is something that can be a difficult task. But if your body language is calm, you're talking in a very calm tone, and you're able to share with them that this is all, we're all doing this to help you feel better. Very often they calm down and they pick up, ma'am talked about mirror neurons. So they pick up from our body language very often and take some time, but calm down. Patients who are confused. So you have patients of dementia, patients with cognitive issues, patients in delirium. So when they are confused, it's again very difficult to build a rapport with such patients. So keep your conversations brief. Only take what is necessary when you're talking to such patients. Take more of the history from the relative. No point in shouting and screaming at such a patient and trying to make sense from what they're saying. So keep your interview brief. Keep it to the point. That will help when you have such patients. You have patients who are reserved or uncommunicative. So like I remember about a year or so back, I saw a patient who had paranoid. He was basically diagnosis based on history was paranoid schizophrenia, and he just came and sat, and he sat like this, and I kept trying to ask him questions, and he was just kept nodding his head. So sometimes you have to actually think on your feet. So then I asked him, so I kept saying, "Baat nahi karenge?" He said, "No." I'm like, likhenge kya? So then I wrote and gave it to him. He actually replied back in writing. So sometimes patients who seem uncommunicative or unresponsive, we may have to see or approach. So the issue that was happening with that patient I just described was that he was having command hallucinations, which was saying, don't speak, which is why he was not talking. But when you found another way of communicating with him, he was comfortable enough to write and say whatever it is, because the voices didn't tell him that. So you have to sometimes think a little out of the box or think on your feet while you're having the conversation. And that can only happen if you're being attentive. You may have hostile, violent, or agitated patients. Do remember your safety is prima facie in all of this. So ensure that you're in a safe environment first, that you have space to exit out, you're not boxed in, and have a calm body language. Do not shout, do not scream when you're trying to be with such patients, because even the smallest of smallest things can act as triggers. If you are calm, you are assertive, you are talking to such patients, it is easier to talk them down. With practice, of course, you also understand where verbal de-escalation can happen and where the boundary is crossed, in which case then we may have to resort to chemical restraint. So make sure that your safety is important here. Don't spend too much time in standing next to the patient and wait for them to do something and then say ki chot lag gayi. Overactive, restless patients or over talkative, like we see in patients with mania, they very often, it's easy to build a rapport with them, but they kind of take over the entire conversation. So there again, shifting the transitions, trying to get to what is important so that you get what you need becomes a challenge. So with this, I just come to the last part. This is what I want you all to take home from this talk. We saw the definition of rapport. We saw that it is important for positive patient outcomes. And we saw all the factors that can affect patient, provider, as well as systemic. And being in the present, active listening, and empathy are key definitely to establishing rapport. But I think most important is be patient, reflect. This is something that I keep telling my residents also. You see so many patients day in, day out. Take some time to just think back to conversations where something was difficult, where you had a difficulty in forming a rapport. You can always talk to your seniors or you can talk to your consultants where there was an issue or problem. So when you reflect on this, it becomes easier for you when you see such a patient the next time, so that your skills get improved when you're forming a rapport, when you're taking history. And of course, keep practicing. The more patients you see, the more your experience builds, the more comfortable you become. Thank you for your patient listening. I think Prajakta and Sir, over to you both.
Yes. Lovely presentation, Dr. Sri Lakshmi. Very exhaustive. I wish I had learned all these things right in my residency days. Anyway, I don't want to talk too much right now. I think we have some videos being played, right, Prajakta? So can we?
Yes, I'll try to play the videos. Let's see if the sound
Maybe
comes.
we
So
have some,
basically, the
comments and
idea was
interactions
that
after the video. Yeah, sure.
Prajakta, do you want to tell the audience that what is expected before?
So we had a small activity plan. We don't know how it's going to turn out because the videos are a little I mean, we don't know whether they're going to be audible, but we have videos of two situations where we would like the audience to see the video, try to hear it, and we have questions after that. Let's see if let me try playing the video first.
Is there any issue, Prajakta? Is there any issue?
Have you played the video? Because your screen is still on the PowerPoint only.
Audible?
No, we are seeing the screen with the slide activity.
Oh,
You just stop. Let me try and see. Just stop one second.
मामा और कितने पेश
It started, but it froze.
पेशेंट्स हैं यार, दिमाग खराब हो रहा है, हो
Yeah.
गया खत्म?
Are you able to hear, ma'am?
Yes.
it is audible.
Yes.
Audible? Okay. Then I'll play. I'll just start again.
मामा और कितने पेशेंट्स हैं यार, दिमाग खराब हो रहा है, हो गया खत्म?
सर
हम्म
मैं बैठ सकती हूँ?
बैठ जाओ।
गुड आफ्टरनून सर, माय नेम इज सिमरन। मुझे थोड़ा दिखाना था।
दिखानी तो आए हैं, बोलिए अभी क्या तकलीफ है?
सर मुझे ना वर्क प्लेस पे काम नहीं हो पा रहा है, मुझे बहुत उदास लगता है, पूरा दिन बेड से बाहर आने की इच्छा नहीं होती है,
समझ
कोई
सकता है।
डांट देता है तो मैं बहुत ही दुखी हो जाती हूँ मुझसे।
आंटी था तो दुखी हो जाते हैं। उम्र कितनी है आपकी?
26।
अच्छा, बचपन में माँ बाप ने कभी डांटा नहीं क्या आपको? टीचर ने नहीं डांटा कभी? हाँ, डांट देता तो उदास हो जाते हैं। अच्छा, बोलिए बोलिए, उदासी हो जाता है, डांट देते हैं तो फिर क्या होता है और क्या होता है?
सर मैं कोशिश करती हूँ हैंडल करने के लिए, पर नहीं हो पा रहा है मुझसे। मैं घर पे भी बात करने की इच्छा नहीं
आप
होती है।
अकेले रहते हैं ऑफिस में कि और भी लोग हैं?
सर 10 लोग हैं।
तो बाकी सबसे तो हैंडल हो रहा होगा।
जी सर, मुझे भी यही लगता है, वो लोग हैंडल कर लेते हैं पर मैं नहीं कर पा रही हूँ। मुझे समझ नहीं आ रहा मुझे क्या हो रहा है।
जॉब लेने से पहले सोचना था ना, ये जॉब सूट करेगा कि नहीं करेगा। ले लिया जॉब, अभी हैंडल नहीं हो रहा है। खैर छोड़ो, बताओ हैंडल नहीं हो रहा है, इसके कारण उदासी आ रही है, और क्या तकलीफ हो रही है आपको?
सर मुझे पसंद था ये सब और मैंने अपनी मर्जी से लिया, पर
सिमरन, मैंने आपसे क्या पूछा? पेशेंट्स वेट कर रहे हैं, मेरे पास समय नहीं है। जितना पूछा जाए आप अगर उतना बताएंगे तो बेहतर होगा। उदासी के अलावा और क्या तकलीफ हो रही है आपको?
सर बेड से निकलने की इच्छा ही नहीं होती है।
अच्छा,
ऐसा लगता है पूरा दिन रूम पे ही रहूं, बाहर नहीं जाऊं।
क्यों? पार्टीज वगैरह नहीं करते हैं? वीकेंड पार्टी, सैटरडे नाइट पार्टीज, वो तो हो रहा होगा। सिर्फ काम के समय, है कि नहीं? बोलो बोलो, बोलते जाओ, मैं सुन रहा
लगता है कि पूरी नहीं हो रही है, सोते रहने की इच्छा हो रही है।
हूँ। क्या? सोते रहने की इच्छा हो रही है? सो रहे हो ज्यादा कि नींद नहीं आ रही है? थोड़ा क्लियरली बताओगे?
पता नहीं सर, भूख भी।
सिमरन, मैंने भूख का पूछा क्या? नींद का बात कर रहे हैं, नींद का तो समझ आता होगा आपको।
जी सर।
बहुत सरल प्रश्न किया मैंने। नींद आती है कि नहीं आती है, हाँ कि ना?
जी।
हाँ कि ना?
आती है सर।
आती है, ठीक है, आगे बोलिए, अभी भूख का बोलिए।
भूख भी, कभी मैं खाना भूल जाती हूँ, कभी मैं खाती हूँ तो मैं बहुत खाती हूँ, ऐसे समझ में नहीं आता, कंट्रोल नहीं होता। जब ये टेंशन होती है तो बहुत कुछ होता है। अभी कल ही मैंने
नहीं, बीच बीच में भूख बढ़ जाती है, कभी कभार भूख नहीं लगती है, ठीक है। और
अम,
इसके अलावा और कुछ होता है? मन में हमेशा क्या चलता है आपके?
सर बस खुशी नहीं होती जब सब हंस रहे होते हैं, मुझे खुशी महसूस ही नहीं होती है। अम, मुझे कभी तो कारण भी नहीं पता होता कि मैं क्यों दुखी हूँ, पर बस
कारण पता करने का
रोने
जरूरत,
का।
कारण पता करने का काम आपका नहीं है, क्या होता है वो बता दीजिए। ठीक है। मन में कुछ मरने के विचार वगैरह आते हैं आपके? सिमरन, पूरा दिन नहीं है हमारे पास, मन में मरने के विचार आते हैं क्या आपको?
जी सर।
बताएंगे थोड़ा डिटेल में क्या आता है, कब आता है?
सर जब कुछ ज्यादा हो जाता है
एक मिनट,
कोई।
एक मिनट। हाँ, ज्यादा हो जाता है
तो सर बस तभी ऐसे लगता है जीने से क्या फायदा है ये सब करने
हाँ,
का।
क्या फायदा, खत्म कर देते हैं चैप्टर। हाँ, मरना तो आसान है, स्ट्रगल तो करना नहीं है आजकल के लोगों को, है कि नहीं? सब कुछ तो थाली में परोस के मिलता है। मन के मुताबिक कुछ बात नहीं हुआ, खत्म कर देते हैं, चैप्टर खत्म। तो चैप्टर खत्म करने के लिए कुछ किया है आज तक?
जी सर, 4 साल पहले थोड़ा।
4 साल? 4 साल से तकलीफ है? अभी तो आपने बोला ये काम का तकलीफ है। तो 4 साल से आप क्या कर रहे थे मैडम?
सर ये थोड़ा कोशिश किया था मैंने, पर
नहीं, वो मैं देखता हूँ, पर 4 साल से आप क्या कर रहे थे? ट्रीटमेंट वगैरह लिया कि नहीं लिया आपने?
सर मेरा ब्रेकअप हुआ था।
ब्रेकअप हुआ, बॉयफ्रेंड चला गया, लगा काट के बॉयफ्रेंड वापस आ जाएगा, है कि नहीं? आया बॉयफ्रेंड वापस? हाथ में निशान जरूर रहेगा आपका।
Shall I think we've seen quite a bit of the video, na? Shall I pause and can we go ahead
Yeah,
with
yeah.
the
Yes, we can pause and ask questions. Yeah.
go ahead, Prajakta?
So I had put up a few questions that we would wanted to maybe ask the audience to. First was, what are your observations about the doctor's attitude? Someone is saying empathy is absent. Any other answers? That is very judgmental.
I think there's also mentioned doctors multitasking.
Yeah. Not an effective consultation.
Sir, you wanted to whatever.
Yeah. Correct. So any more observations? In fact, when we took the trial of the video, the audio wasn't playing so well. Even in the absence of the audio, one could make out from the body language of the doctor that something is not right. Am I right?
Yes.
So what is it in the body language? So both Shilpa and Dr. Srilakshmi, both of them mentioned about communication. What is non-verbal communication? That is the most, I think that is the first communication we learned as human beings. When we were small babies, non-verbal communication was the first communication that we learned. Words came much, much, much later in our life. Let's not forget that. So we are very sensitive to non-verbal communication. Mirror neurons pick up non-verbal communications like anything. So let us be sensitive to this very concept that so yeah, doctor lacks empathy. Somebody says way of sitting. Again, if you notice, from a profile point of view, that the shoe, the foot of the doctor, who's sitting like this, it's so intimidating and it's so irritating.
It actually hits you. So imagine the patient.
Yeah, exactly. Almost very well enacted, very well enacted. I must congratulate.
We must thank our assistant professor, Dr. Parijat, and our resident Dr. Simran.
Congratulations to both of them. Wonderfully acted. And I still remember the role plays which I used to do along with Dr. Vyang Vahia for, when we used to train GPs for doctor-patient communications, where I used to act as a patient. Anyway, so coming back to this, what is important here, I think, is not being goody-goody. I mean, it's not about being goody-goody. When you are empathetic, if you have read Stephen Covey's book on how to be effective, he talks about two concepts. One is personality ethic, the other is character ethic. So if we are able to build some of these concepts in our character itself, not just personality. Persona is just a facade which is external, which you put up. That is not what we are trying to talk about. We are talking about building up empathy, allowing empathy to get ingrained within us as a quality of communication. So begin with non-verbal communication, words will follow. Anyway, any more comments, Shilpa, Srilakshmi?
Yeah, I think you covered most of them. The other thing was also interrupting, which during rapport building, Sri Lakshmi had spoken about. So he interrupted. He was very condescending. You don't tell me, or जो बताया, जो पूछा वही बताओ. All those things. Then also passing judgments that ऐसा थोड़ी होता है, या पार्टी में जाते हो, या whatever. Only when things don't go your way, you do this. It's like a labeling a generation, आजकल के बच्चे, or something he said, I don't know what. But it's more like prejudice. So all that also came in. And I think all those things that were there in Sri Lakshmi's slide with a red cross, that what are the no-nos or don'ts, all of them, I think they were there in this.
I think the patient's reaction said it all in terms of, if you just look at how uncomfortable she is, that in itself, I mean, if you just observe, I think that helps very often to correct the path that we are taking in the conversation.
And also reading the body language, that she suddenly became tearful or looked down and stopped talking. So instead of being observing that and asking something about it, he just went on with his own question that had to be asked. So, the cue was not taken at all.
Do we play the other video?
We play the second video.
Yeah.
Maybe a little bit.
Yeah, okay.
Just to feel nice.
Yeah, just a sec. We always, we show what shouldn't be done, and it's always good to show what needs to be done as well.
Little bit. I think you time it, Prajakta. Don't play it for too long.
We did start maybe 10 minutes late, but we are past 9 o'clock.
Yeah, so maybe for a few minutes you play, and then again let people give their observations maybe.
Yeah, I'll just share the screen. I've just opened it.
So,
please, say.
good afternoon, sir.
Good afternoon.
सर मुझे थोड़ा दिखाना था, भेजा मुझे किसी.
Sure. So I am Dr. Roy, and I am going to consult you today. आपका नाम मैं जान सकता हूँ?
मेरा नाम सिमरन है.
Okay, सिमरन.
मैं अभी जॉब कर रही हूँ.
जी.
मैंने B.Com किया, उसके बाद M.Com किया, और अभी मैं जॉब कर रही हूँ.
Okay, and how old are you, Simran?
I'm 26 years old.
Nice.
I live with my family, and अभी थोड़ा issues था. I thought I should come here after a long time.
Very good. So before starting the interview, before asking you questions, क्या ये आपका पहला बार है आप साइकियाट्रिस्ट के पास आए हैं?
जी सर, मुझे प्रॉब्लम्स थे बट मैं कभी आई नहीं, बट दिस टाइम
So I want to reassure, we are just like any other doctors. So आपको कुछ झिझक लेने की या डरने की कोई बात नहीं है. हम आपके हेल्प के लिए यहाँ पे बैठे हैं. आपके मन में जो भी है आप खुल के बताइए ताकि हम आपकी मदद कर सकें. और एक चीज, आप जो हमें बताएंगे that is going to be 100% confidential. वो आपके और मेरे बीच में ही रहेगा. So अगर मन में आपके ऐसा है कि मैं ये बात शेयर करूं कि ना, आप बेझिझक कर सकते हैं जितना आपको कंफर्टेबल लगे. तो आपने सिमरन बताया कि यू हैव नॉट बीन फीलिंग वेल, आपको अच्छा नहीं लग रहा है. थोड़ा विस्तार में बताएंगे क्या हो रहा है.
सर 6-7 इयर्स बैक मेरा ब्रेकअप हुआ था. उसके बाद मुझे बहुत उदासी और किसी काम में इच्छा नहीं होती थी. मैंने अपने आप को हर्ट करने की भी कोशिश की थी. उसके बाद मैंने नहीं दिखाया था. आई वॉज वर्किंग एंड अभी कभी भी कोई मुझे कुछ कह देता है तो मुझे बहुत ज्यादा असर होता है. मेरे साथ वालों को नहीं होता बट मुझे इतना होता है. आई कैन नॉट लेट इट गो. आई कैन नॉट स्लीप एट नाइट. मुझे बिस्तर से उठने की इच्छा ही नहीं होती है. एंड मैं सुबह उठती हूँ तो भी मुझे फ्रेश फील नहीं होता है. I feel like crying most of the time for no reason sometimes. And so, आज फाइनली मैं इसलिए आई हूँ क्योंकि कल वर्क प्लेस पे किसी ने मुझे बहुत बोल दिया था और फिर मुझे बहुत ज्यादा जोर से रोना आ गया. मैं एकदम सारे सीनियर्स के सामने I lost it and I had a breakdown.
Very sorry to hear that. So सिमरन, जितना मुझे समझा आप.
Shall I pause, ma'am?
Yeah.
Yeah, I'm stopping the shooting.
So I didn't want to put in all the questions, but if you start and people can answer, what are the differences that you saw in the communication that happened?
Have the residents left after seeing the bad people?
Yeah, no, we still have 40 people. But yeah, so someone saying eye contact was maintained, active listening, eye-to-eye contact. Doctor was very respectful and empathetic. Reassuring.
Also clean
How do
shaven
you?
as compared to the first one.
Oh, and just when we stopped, I saw that he was trying to paraphrase or kind of summarize what she was trying to say. And most of the times he was not talking, he was listening and just nodding or saying ha, etc., which is what we were talking about, and Sri Lakshmi reiterated it.
This present attentive, he has interest, the input, patient is comfortable, acknowledgement of emotions.
Yes, and actually this video ends with the patient feeling satisfied and saying that आपसे बात करके अच्छा लगा, and whatever he said, she will do it, whether it's follow up, whether it's following up with the mother, whether it's taking the medicines, etc., which is what you want to achieve with empathy and rapport building. That is your ultimate aim.
We also seem to have built a rapport, ma'am. They are using words which we used in our talk. So I think
Oh,
that's
great.
that's a
So
good.
they were mindful,
Attentive.
attentive. Yeah.
Yeah. I think those are the last of. If anyone has any questions, I think Prajakta. I don't think anything came, no?
No.
Right. I think
Yeah. No question.
all right, sir, if you would want to say some.
Yeah, just a few points. Both presentations were wonderful and enlightening, and to the point, very lucid, very clear. A few points that maybe by virtue of the gray hair that I have, I can talk about. One is, as Shilpa and Shri Lakshmi, both of them mentioned, that we need to blend history with MSc. It's not taking history first and then eliciting MSc. The two things go hand in hand. That's one. In sales, there is a concept called phatic communication, PHATIC, which means it's a communication which serves some social function. So, you may not be possible with each patient in a busy OPD, but whenever possible, if you talk about the native place, weather, the travel, or maybe a cricket match which happened, or a movie that the person saw, especially with children, adolescents, these kinds of things are very helpful. Or maybe a comment like, you're looking good today, or looking tired, you're looking worried. So some such things can help the person reflect and express emotions better. I still remember a physician friend of mine once asked me, what do you do when a patient starts crying in front of you? Because she used to be very uncomfortable with crying patients. So my immediate response was, I give a tissue to wipe their tears. Because an overwhelmed patient cannot even find a handkerchief, when they're overwhelmed with emotions. So that is itself is a wonderful gesture. So you're indicating two things. I'm here to wipe your tears, number one. Two, it's okay to cry. So expressing emotions in a clinical setting is very important. Another thing, as an extension of what Dr. Sri Lakshmi mentioned about, there are some patients we genuinely do not like. Let's accept that. People who beat about the bush, who are circumstantial, tangential, who are very vague in giving histories, or people who talk a lot in general, or non-compliant patients, people who don't listen to our advice, intoxicated patients, patients with a lot of cluster B traits who are manipulative, histrionic, attention seeking. And we also don't like patients who don't improve with our treatment, right? So in general, our attitude starts changing. Let us be mindful of our own attitude. So bring the focus from the patient to yourself when such things start happening. Another thing is, one can be non-conventional in a clinical setting, especially when it comes to children and adolescents. I still remember young kids, I am 6 feet, and the tiny 5-year-old who's sitting on the chair who finds it difficult to look at you. So in that case, I would pick up the child, keep the child on the table, and then have eye-to-eye contact. That's okay. As long as you take the child's permission, as long as you don't intrude upon somebody's personal private space, it is okay to be non-conventional. And lastly, if you're really running out of time, with the physical time, which is very important, you can call some patients separately. I mean, in KEM, when I was a resident, I remember I used to call these patients separately in the evenings for an interview, when I used to be a little relaxed, so that I have enough time to collect data from the patient. So these are things which can be talked about. There's a lot to teach, but more than that, it's a lot to learn. Thank you, Dr. Shilpa, Dr. Sri Lakshmi, for wonderful presentations. Thank you, Prajakta, for calling me. Thank you, IPS West Zone, for inviting me. And congratulations on selecting this beautiful topic. Thank you so much.
Thank you, sir.
Sir, I think, sir, very nice. Sir, for being here and issue over time, but thank you so much. Also, we hope that everyone's filled in the feedback form so that it helps us. And thank you, Shilpa ma'am. Thank you. And
Thank you, Prajakta, for running the show very well.
we will see you soon for the next session, and we will update some of the.
Thank you.
Thank
Good
you.
night,
Bye.
everyone.
Thank you.
Very nice session.
Thank you, Dr. Bhavesh.
Thank you.
Very
Bhavesh.
nice session.
Thank you, Bhavesh bhai.
Thank you. Good night, everyone.
Good night.
Bye. Good night.